So thank you both so much for joining us, and we'll hand the mic over to you.
Okay, great, thanks. Can you guys hear me okay?
Very well.
Good, okay, perfect. We were asked to answer a couple of questions initially and then take some questions from you. The questions included, could ADAP funds be used for pre-exposure prophylaxis? And what about 340B funds? Could they be used for PrEP, be paid for with 340B funds and get the discount? So I'm going to start off by talking briefly about the Ryan White program. Essentially, the answer is that the ADAP program requires people to be HIV infected. They're for medications for people with HIV infection, so that they're not able to be used for PrEP. And I'm going to turn it over to Krista to talk more about the 340B program, because it's a pretty amazing program in the federal government.
Thanks, Dr. Cheever, and thanks for having us. For those of you not familiar, the 340B program is a program that substantially reduces the cost of outpatient drugs for federally qualified and supported safety net providers that are defined in statute. And the overall intent of the program, as defined by Congress, is to give entities that are covered by the program access to price reductions so they can maximize their federal resources as far as possible and treat more patients and provide more services. The 340B program, it requires drug manufacturers that participate in Medicaid to offer outpatient drugs to these healthcare organizations, again, at a discounted rate, anywhere from 25 to 50% off the medication. It's usually higher for the brand name products. Eligible healthcare organizations include the Ryan White clinics, ADAPs, disproportionate share hospitals, family planning clinics, children's hospitals, community health centers. There's 20 different entity types that can participate. And once they register with our office, they are then listed on our database and then can start purchasing discounted drugs, but they have to be provided to 340B eligible patients, which we define in guidelines, to ensure compliance with the program. So it's important to note that, again, that once you are listed and you can purchase these medications, the goal is that the entity can bill private insurers and Medicare for insured patients at a price where above cost to provide the spread that they can then use towards those that cannot afford it. So it's a way to bring in both savings on the drug and a form of revenue that can then be used to cover costs for uninsured or to provide more services to the patients that are already being served. So that's the intent and how the program is set to operate. So it is not limited to those that do not have insurance. And in fact, it works by including those that are insured, billing at the normal rate, and then taking that spread and applying it to the uninsured. While 340B program doesn't say then what the entities have to do with these savings, the grant programs, though, may stipulate that the revenue has to be reported and you have to do certain things with that income, like put it back into program. But really is a tremendous benefit and resource for the safety net providers to further spread costs that they have. We do audit, and manufacturers do audit these entities to ensure they're in compliance with the program. But we have available resources and a call center on our website for anyone that wants to learn more information about the program and whether you can gain access to it.
Okay, great. Are there any questions, follow-up questions to those two issues, use of ADAP funds or use of 340B funds to pay for PrEP? So a question that I have for the two of you is, you know, we know that we're very excited about the potential for PrEP to, improve prevention efforts, HIV prevention efforts, and we also know that, there's a preventive effect of HIV treatment. And so if we could scale up treatment, improve treatment adherence, lower community viral load, and do PrEP at the same time, we could have the most effect on the epidemic. So given that, how are HRSA and CDC coordinating the rollout of PrEP and work on treatment as prevention?
Great, thanks for that question. HRSA and CDC have collaborated extensively in the past, and we continue to collaborate, particularly around prevention with positives, as well as increasing testing in community health centers. Within the federal government, the CDC has taken the lead for implementation of PrEP as part of a package of high-impact prevention, and we'll work with them as we can around that rollout. Certainly in terms of thinking about where do you have expertise around antiretrovirals or using antiretrovirals or risk reduction counseling in clinical settings, many people have discussed that Ryan White providers are well situated to provide those types of services, and certainly they can't use Ryan White funding to do it. They would have to have either, at this point now, in many parts of the country, we'll have many more people insured, so they can bill insurance for certain types of activities around counseling and testing and laboratories that we would gather in relation to using PrEP. So we continue to work with CDC on this, and I don't know who, I think Greg is at the meeting. That's what I was told. Greg Millett,
He is
there?
Yes.
Yeah, so I would have him comment on that as well.
Sure. Well, actually, Laura, I'm going to be speaking after you, talking a little bit about what the federal government is doing for the national HIV strategy, and specifically with PrEP, and I'll bring up some of the initiatives that both CDC and HRSA are doing as well.
Okay, and speaking to the issue of treatment as prevention, just briefly, that really, that is something we've been pushing hard in HRSA with the change in the HHS guidelines several years ago to offer treatment or consider treatment for everyone that's HIV infected. And certainly the Continuum initiative that the White House pushed out through the executive order over the summer is another great opportunity for us to make further strides in that, and you'll be seeing us have several activities next year really targeted towards trying to increase the number of people that are retained in care and are virally suppressed.
Great. Yes.
Hi, Laura. G. McGuire. How are you? We were looking at whether we're talking about treatment as prevention or we're talking about strategies around PrEP. You know, increasing the overall universal testing routinely is going to be really important. And we looked at data in terms of the health centers earlier today, which, you know, I know you're familiar with. And so I'm wondering, what's HRSA's strategy just in the HIV routine testing in terms of moving that along across, not within the Ryan White programs, but really truly across the community health center structure?
Okay, so I should say that Renee Sterling is the lead in the Community Health Center program now for HIV, and she could not be here today because she had a required training, but she was trying to join us but couldn't. The CHC program in the last few years has really moved in terms of policy first, putting out PINs, which are policy information notices, program information notices, discussing routine testing. This year, they do plan on having a major initiative around better linking with CDC and getting routine testing, linkage to care, and some basic HIV care services into community health centers, so you'll see that. But I think that they have, since especially since the USPTF changed their guidelines, there has been a much bigger push in the Community Health Center program here in HRSA, because they feel that now they have sort of the backing of the entity that many of their grantees would look towards in terms of preventive services. So you'll see increasing activity in the next year, but their goal is to increase that. We in Ryan White have received funds from CDC that have gone to the AIDS education and training centers to specifically target increasing routine testing in community health centers, and that training has been very effective.
Hi, Laura Blaine Cutler from New York City. Just to follow up on that question, I'm wondering if one of the things that has been discussed recently is making and publishing an indicator for federally qualified health centers around routine screening and posting that indicator on the BIPIC website. And I think that would be very, very powerful. I wonder if you're able to speak to that a little bit more.
Yeah, I can tell you that they have been working on it. We're going to, at the CDC HRSA Advisory Committee meeting, we're actually going to have a session where they're going to be discussing that at the CHAC. The CHAC can be available virtually this time. So I would encourage you to log on to it. There's information in the Federal Register on exactly how to do that. That was published in the last couple of days. But yes, they are definitely pursuing an indicator. They're trying to figure out whether the indicator, some of their issues are whether the indicator looks like the USPTF recommendations or whether it looks like the CDC recommendations, because they're not completely aligned in terms of exactly what they say to do. So they're just working that out, but they do plan to pursue that.
This is Guillermo Chacon. It's good to see both of you even through this wait. Lovely. I just wonder if you could talk to us about, I know there was an HHS assessment about a very low, I think it's 20% of HIV testing among healthcare centers. And if HRSA has been doing any assessment on that, and also on the challenges to improve more people to be viral load, because it's so low in terms of the treatment cascade.
Right, so thanks for that. So in terms of the study that was done that showed what proportion of community health centers were doing routine testing, I can't speak to that specifically at this time, but that's something that I can have Renee talk about at the CHAC, just to have something on public record about that. In terms of the viral suppression rates, so the first thing we did was we looked within the Ryan White program to see how well we're doing in the context of Ryan White. Once someone hits the door in a Ryan White program, over 74% of them or even more are virally suppressed. So when they get into the Ryan White setting, they do better than they do generally. So we've been actually now increasing our efforts with CMS and others to look across all aspects of care inside and outside Ryan White programs. We know we have much more work to do in terms of testing and linkage, but we know that the types of services people are getting in Ryan White are helping people do better than the national average.
Just a follow-up question, Guillermo Chacon, still. Is HRSA ever developing like a national assessment in terms of how to reduce the stigma, especially homophobia among healthcare providers? Just as another big concern that I'd like to hear your comments.
Right, so certainly stigma is a huge issue in HIV, and it really makes it very different than other types of chronic diseases when we're trying to deal with that. I know that as part of the White House continuum effort, we are specifically looking at stigma and what we can be doing around stigma. And I welcome specific kind of evidence-based recommendations you have of what we should be doing amongst providers groups. The AIDS Education and Training Center for years have targeted providers of the safety net and specifically community health centers to try to work on reducing stigma and normalizing taking care of people with HIV, and that's still a goal we have. But we would gladly take any recommendations people have, particularly if they're evidence-based recommendations or recommendations for pilots or some type of testing we could do to develop new interventions.
Great. Well, I just have one more question. So we know that Medicaid in a number of states is covering PrEP in Massachusetts, New York, Washington, D.C. I learned last night that in Florida, Medicaid is refusing to cover tenofovir, emtricitabine for PrEP. And then there's a couple of other states where they're requiring prior authorization. I know that CMS is a different agency than HRSA, but I know also that there's an interagency working group of a number of leaders, working on HIV prevention care throughout the federal government. And I just wonder, given that Medicaid is at least 50% federally funded, in some states up to 2/3, is there anything that the federal government could do to encourage Florida to reconsider that decision?
Yes. When in traditional Medicaid, covering medications is an optional service. I think all of Medicaid's covered, however. In the expanded Medicaid under ACA, it's required. I do not know. So in Medicaid, they are required to cover all medically necessary drugs, and maybe it's not considered medically necessary. They're getting through that loophole. I would really need to defer that to Stephen Chaw, who is the head of, he's the chief medical officer in Medicaid and CHIP programs, and he could better answer that question. So it is something that we can I'll specifically send an email and ask him that and get that information back to you. I don't know if he'll respond today or not, but if he does, I'll send it back.
That would be great, Dr. Cheever, and we'll share that with the group whenever you can get that answer. Well, thank you very much, Dr. Cheever and Dr. Pedley. We really appreciate your time today. Have a good day.
Thank you so much.
Okay.
Bye-bye.